Experience holiday cheer at Tanger Outlets with savings up to 70% off your favorite brands. From fragrances to accessories and the latest styles, discover the best gifts for everyone on your list. Save big at Nike Factory Store, Michael Kors, Under Armour, Coach, Polo Ralph Lauren, Kate Spade New York, and so many more. Unwrap the best at Tanger Outlets. Hundreds of brands, endless gifting options. Plan your trip at Tanger.com.
All right, let's get into a segment we like to call What's Up, Doc? Normally, we do this on Thursday mornings, but because of scheduling conflicts and other things, we moved it to a Friday morning. I didn't think anybody would mind.
No, we'll be fine.
Weekend's still looking at us, and you're going to walk away healthier because you're going to learn some stuff from our guest this morning from Mercy Health. It's Dr. Abdullah Altayeh. We're talking asthma, among other things. Dr. Altayeh, good morning to you.
Good morning, sir.
How's everything going?
I'm doing well. How are you doing?
Well, we have nothing to complain about. Tell us a little bit about you.
So I moved to Rockford back in 2010. Been here for about 12 years. Enjoy the city. I'm a pulmonary critical care physician. I trained initially at Chicago Medical School here for internal medicine. I went to West Virginia, Huntington, Marshall University for my pulmonary fellowship.
The Thundering Herd.
And I trained at Rochester, Minnesota for my Mayo Clinic critical care fellowship, and then came here.
Fantastic. And you've been enjoying the Rockford area ever since?
Love it. We've stayed, and we're planning to stay here for hopefully another 10 more years.
How many times do you go to Beefaroo a week?
That's the true test, Doctor.
Friday.
That's how we'll know.
Friday, my kids want to go there.
Friday,
Okay, Friday's Beefaroo Day?
Kids going to Beefaroo.
Okay.
When did you know your medicine was where you wanted to wind up?
So, to be honest, my father was a physician. He trained in Britain. He was a chest physician, and I guess over time I felt that was my calling. I like father, like son.
Mm-hmm.
During my internal medicine training, those were the brutal days when you get into the hospital, you don't leave the hospital until 3 days later.
Right.
There's no such thing as a 24-hour limit or a 30-hour limit in the hospital. Those are the days you'd walk around for 3 days straight. Got exposed to very sick people over at Mount Sinai in Chicago, downtown. Those are very, very sick patients there, and the critical care unit became something I admired, and after that, I joined pulmonary and critical care. And while I'm here at Mercy, I became a neurointensivist as well.
Were these specialties something your dad was into as well?
He was a chest physician, so pulmonary medicine.
Okay.
Yeah.
Outstanding. So it seems like, you were born to do this, kind of the family business, for lack of a better term.
Yeah. He was a great teacher.
All right, let's talk a little bit about critical care, intensive care, pulmonology. For people who don't know what that means, break it down for us.
So pulmonary is basically studies of diseases of the chest. You see many illnesses, anything related to shortness of breath, asthma, as we'll talk about today, chronic obstructive pulmonary disease, pulmonary fibrosis. Patients, one of the leading cancer deaths worldwide is lung cancer. Smoking is the number one cause here. So we get a lot of lung nodules, lung masses, fluid around the lung, fluid in the lung, pneumonias, especially now with COVID. During these past few years, thankfully things are getting better, but COVID was a big deal for us. You did not want to see me in the hospital, that's for sure. When they called me to the hospital, that was the last person you wanted to see, because that eventually led us to take these patients to the critical care unit. Many of these patients ended up on the respirator. So the other hat that I wear is the critical care hat. Patients are critically ill, requiring CPAP, BiPAP, and eventually respirators. Sometimes we had to do something called ECMO here, where we'd bypass the lungs actually and put them on a machine where we'd oxygenate the blood directly. So it's very sick people that we'd see.
We do a lot of.
Go ahead.
I was just going to say, it sounds like you wear a couple different hats there in your job. What is kind of the breakdown? How often, what percentage do you see these critical care, patients, and how often is just, attending to regular patients, for lack of a better term?
So the way my job is divided up, I have a pulmonary clinic where you see patients in the outpatient setting. Then we see patients on the floors in the pulmonary where they're stable. They have, stable breathing patterns. They just have maybe a pocket of fluid that we have to physically drain, or they have a lung mass that we have to diagnose and biopsy. We also do outpatient procedures called bronchoscopies, where we go down into people's lungs and get biopsies from them. And then finally, quite a bit of our time we spend in the intensive care unit, at least 10 days of the month, where we manage patients in the intensive care unit.
Doctor, on the topic of asthma, maybe as a guy in my 50s, I have a poor recollection of it. But growing up as a kid, almost like peanut butter allergies, I just don't ever remember seeing that sort of thing coming up. Peanut butter allergies, I didn't see at all. And I think throughout my entire time of going to school, from elementary to middle to high school, I maybe knew of one person who had asthma. Now you seemingly hear about it and see it everywhere, every day. Is that just my misperception in remembering it, or have we seen a definite uptick over the decades?
So, there's different levels of asthma. It may be mild, moderate, and then more severe. So many people have asthma. It's actually very common. About 10% of Americans will have asthma. Over 25 million cases a year you'll see. And most of them are diagnosed before the age of 7, so that may have been a factor. It may go away over time. So maybe when you're in 3rd, 4th grade, the symptoms get improved. But then later on, it can creep up in life, later on in your 20s and 30s. So it has more of a variation over time. And different places patients can get exposed to, different seasons. So it's not always all the time present in patients. Unlike, for example, chronic obstructive disease, where it's an irreversible process where patients are always short of breath, coughing, and whatnot. Asthma is more episodic.
And I also think I think of asthma as a young person's kind of disease. I don't know if that's just because they're the only ones I see with inhalers all the time. And you mentioned that you can grow out of it and maybe slide back into it. What changes in somebody's body to let them grow out of asthma?
So again, it's hormones as we get older. Many kids as they reach puberty, so the hormones of puberty will help change the physiological process of their body, and those hormones will actually help reduce the triggers to those asthma. A lot of times we get it as we're young because you're born, there's new environmental triggers that you're exposed to. Your body may get used to them. You move to somewhere else, you get other triggers that stimulate your asthma, which basically is what happens is your airways narrow down. You get this inflammatory disorders of the lung, and you start to wheeze, cough, and get shortness of breath.
Now for people who are completely unfamiliar with the topic, but know maybe something is a little off? You mentioned wheezing, shortness of breath. What are some of the other common early warning signs or symptoms that could indicate to someone that maybe I should get this looked at? It might be asthma.
Yeah, that's a great question. It's like I said, these symptoms are episodic, so they're not happening all the time. You may having some shortness of breath after you start exercise, 5 to 15 minutes later, where you start noticing some chest tightness, a cough. Other patients may be waking up at nighttime with a cough or shortness of breath. The most common thing is like when you're exposed to certain environmental triggers. For example, you go to a friend's house that's got a cat or a dog, and you start feeling, hey, there's something wrong. My chest is feeling a little bit tight. I'm coughing more. I'm getting more short of breath. So that's when you start noticing that there's something wrong here. So you get a runny nose, runny eyes, sore throat at times. All these factors come together, and there's different types of asthma. Occupational asthma, allergic asthma, even medication-induced asthma. Sometimes aspirin can cause us to trigger our asthma.
And are we still? Is the inhaler still the number one remedy for asthma?
Yeah. So there's different types of inhalers that we can use depending on the severity of the asthma. The way I like to look at the lung is that it's got three doors that you can open to help improve or open up the airways. One of those are the short-acting or the albuterol rescue inhalers. Those generally work very quickly. It gives you a quick relief. And within a few minutes, 5 to 15 minutes, you get relief of your shortness of breath. And they're short-acting, and they wear off pretty fast. So they wear off within 3 to 4 hours. Then you have your more longer-acting, depending on your symptoms. So if I get a patient that's using the rescue inhaler often, they're using it maybe 3-4 times in a week, that tells me that their symptoms are not controlled. So they're at high risk of getting bad complications from their asthma. So you try to put them on something that's more longer term of an inhaler as a maintenance or controller inhaler that works on by using steroids, which is another way to open up the airways, or what we call a beta agonist, a long-term beta agonist, or a antimuscarinic agonist. These are also other inhalers that help keep the airways open for us. And depending on your severity, you add more inhalers.
Okay. That makes sense. Mm-hmm. Doctor, we're running short of time, and we know that you are wildly busy looking at your schedule here. Is there anything about this particular topic that we haven't asked you that you would like people to know?
So in this time of COVID, I get a lot of questions of, does asthma increase my chance of getting COVID? The answer to that is no. It may increase the severity of the asthma if you get a pneumonia. If it may increase the severity of the COVID if you get the COVID pneumonia down into your lungs. But the best thing that you can do to protect yourself is to stick to your inhalers and get the COVID vaccine. Especially above age 50, you're at high risk of developing a COVID pneumonia. So definitely vaccinate.
Outstanding.
Mm-hmm.
Dr. Altayeh, thanks for taking time out of what we know is a very busy day and enlightening us on a topic that people hear a lot about but don't know a lot about. Well, now they do, thanks to you. We really appreciate your time this morning.
My pleasure.
That's Dr. Abdullah Altayeh with Mercy Health, and this has been What's Up, Doc, Friday version.